Welcome. In this session, we're going to explore the auditory and vestibular systems. We will identify the anatomical components of both the auditory and the vestibular apparatus. We'll define the vestibular sense, describe the process of signal transduction in both systems, trace the auditory and vestibular pathway from the peripheral nervous system through the central nervous system. For both the auditory and vestibular pathways, we'll examine where they're located in sections through the brainstem. We'll differentiate between the macula and cristae, part of the receptive surface for the vestibular system, summarize the inputs from the vestibular system to the central nervous system, review the vestibular ocular reflex, which controls the position of the eyes based on movement of the head, and differentiate between conductive and sensory neural hearing loss, common to causes of each of these, and identify tests that distinguish between conductive and sensory neural hearing loss. And then we'll identify peripheral versus central causes of vertigo or dizziness. Now, hearing and balance are very different senses functionally, obviously to hear and to be in balance, and yet both of those senses are dependent of information conveyed through the eighth cranial nerve. The cochlea division carries information about sound, hearing, and the vestibular division carries information about position and movements of the head. Both of them have end organs, which have specialized mechanoreceptors that are hair cells. Both divisions of cranial nerve 8 have bipolar cells that send their central process into the brainstem, but their neurons, cell bodies, are located in ganglia buried within the temporal bone. The spiral ganglia is within the bony cochlea, and the vestibular ganglion is within the temporal bone itself. Neurons for both ganglia have peripheral fibers that go out to receptor cells, and the receptor cells are hair cells. These receptor cells are buried within various membranes in the labyrinth, which is suspended within the temporal bone, and we'll examine that membranous labyrinth. We see here the outer ear, which is essentially the continuation of the pinna and normally filled with air. We then see the eardrum, the tympanic membrane, at which begins the middle ear cavity, in which the ossicles, bones that connect the outer ear to the inner ear. And here we see the inner ear composed of the cochlea and the vestibular apparatus, the semicircular canals. Within the ductile networks of the auditory and vestibular apparatus, we see represented here in blue a number of channels that are filled with endolymph, and they are inside a bony tube that outside of the vestibular and cochlear apparatus is perilymph. So we literally have a tube within a tube, and here we see the circular helix of the cochlea and the various semicircular canals of the vestibular apparatus, as well as additional structures, the utricle and the saccular portion of the vestibular apparatus. Seen here in blue is the region in which endolymph is located within the semicircular canals and also within the cochlea, within this membranous labyrinth. And the inside is endolymph, on the outside of that semicircular canal, between the semicircular canal and the bone, is perilymph. We see here in the inner ear the auditory apparatus of the spiral region, and the vestibular apparatus. All this buried within the temporal bone. We see the cochlea up here. If we were to stretch out that cochlea, within it we'll see the organ of Corti. And we see the overall objective is to have air that is vibrating activate a membrane here that will activate the ossicles, these bones that convey sound pressure from the outer membrane to an inner membrane, therefore starting to move fluid through the perilymph. And that perilymph will encounter a membrane at the other end that allows movement of the fluid so that it does not have to be compressed. And we see that that fluid, that perilymph, is continuous for the vestibular apparatus outside of the vestibular apparatus, while the endolymph is also continuous inside the cochlea and inside the vestibular apparatus. The vestibular apparatus including the semicircular canals that have sensory organs that we see here in the cristae, and the utricle and saccule that have their sensory fibers in the maculae, represented here in green. If we stretch out this cochlea, we can see that resting on a membrane buried within the cochlea, resting on the basilar membrane, are the receptor cells, the hair cells, and they're both outer hair cells and inner hair cells. And each of those connects to eighth nerve fibers, which will send their fibers centrally. We see that normally this region is curled in this pyramidal helix that we see represented right here with the bony membrane, that bony ossicles that start the activation of the sound detection process. If we stretch this system out, we can appreciate that sound waves coming in oscillate the membrane right here, the tympanic membrane, start moving of the ossicles, which move the oval window, move the fluid over the basilar membrane, and as a result, this basilar membrane is able to pick up the frequency of activity of sounds. And in that membrane, in that basilar membrane, it turns out that the highest frequencies are represented very close to the origin at the base of the cochlea, whereas the lowest frequencies are represented preferentially at the most distal end of the cochlea, near the helicotrema. And this separation of sound enables us to distinguish different frequencies. Here we see buried within the cochlea the area in which the sensory neurons are located, and that is the receptors are sitting on the basilar membrane right here, and they encounter endolymph that is going to be involved in carrying the sound waves. And we see the spiral ganglion with the cell bodies of the beginning of the eighth nerve originating. We see a little blow up here of the organ of Corti, which is this apparatus in which the basilar membrane has hair cells that are the detectors that extend onto a tectorial membrane overhead, and then they travel back to synapse on peripheral process of the cranial nerve 8. Here we see a blow up of those inner hair cells and outer hair cells, that the relationship between those hair cells, the tectorial membrane, and the basilar membrane will influence their ability to pick up sound. And we see a number of separations of fluid where we have a scala media, a scala vestibuli, and a scala tympani, all different regions within the cochlea that help to conduct in sound waves through this membranous region. The basilar membrane is where the hair cells sit. And the peripheral processes from the ganglion reach out to these hair cells. We can see the hair cells in this electron microscope, and we can see that reaching up from the basilar membrane to the tectorial membrane, we see the very edge of the projections of cilia that actually detect the movement of fluid and of this tectorial membrane relative to the basilar membrane that result in the initial transduction of sound into electrical activity of neural systems. And that happens in part because in the vestibular apparatus, we have a gelatinous material that is up above the hair cells and engages the hair cells, and its movement of that gelatinous material relative to the hair cells and their cell bodies that enables a change in excitability of these receptors. We see an electron microscope of those hair cells extending into the endolymph. The endolymph has a very high concentration of potassium ions, much higher than most other regions. As a result, when there is movement of the hair cells, that tends to open up channels for potassium to enter the cell. As the potassium enters the cell, those positive charges coming into the cell opens up voltage-gated calcium channels. Opening up the voltage-gated calcium channels results in release of excitatory neurotransmitters onto the nerve ending of cranial nerve 8 and increases firing. The intensity of sound is encoded in the rate of action potentials of these hair cells, which then activate the 8th nerve fibers. The frequency is detected by which hair cells are activated. And as we indicated, at the base of the basilar membrane, the highest frequencies are preferentially activate hair cells, whereas at the apex of the cochlea, seen up here and over here, where the basilar membrane is wider, the lowest frequencies are represented. Something like the reverse of a heart, which has separate length of strings in order to represent different frequencies, so also the basilar membrane has different frequencies along its extent. Once the neurons come into the cochlear nucleus, they send their central processes towards the brainstem at the pontomedullary junction. They travel into the brainstem and synapse on the cochlear nuclei, and from the cochlear nucleus they travel some to the same side, some to the opposite side through the trapezoid body up to the superior olivary nucleus. And at the superior olivary nucleus, there's the opportunity to compare the inputs from the two sides, which helps to localize sound in space. From the superior olivary nucleus, fibers travel up through the lateral lemniscus to the inferior colliculus in the midbrain. Fibers, again, some will cross to the other side, some will stay on the same side. From there, they travel up to the medial geniculate body of the thalamus, passing through the brachium of the inferior colliculus. From the medial geniculate body, they travel up to the auditory cortex. That's on the superior surface of the superior temporal gyrus in an area known as Brodmann area 41, also known as Heschel's gyrus or the transverse gyrus, transverse temporal gyrus. Seen here in a cross section through the medulla, we see that cranial nerve 8 sends its fibers into the ventral and dorsal cochlear nuclei at the pontomedullary junction. They tend to branch and innervate both of those before they send their fibers further central. If we move up into the pons, we can see that the fibers from cochlear nuclei are traveling through the trapezoid body and coming up to the superior olivary complex, identified right here. As you can see, some of those fibers cross the midline, right at this pontine level. Others do not cross, and they travel up through the lateral lemniscus. Sound localization is accomplished by comparing the arrival time of input from the two ears to the superior olivary nuclei. Moving up to the midbrain, we see the lateral lemniscus, a fiber tract traveling up to the inferior colliculus. The inferior colliculus in the dorsal surface of the midbrain. As we go a little bit higher in the midbrain, we see fibers coming from the inferior colliculus going off to the medial geniculate body through the brachium of the inferior colliculus, going up to into the medial geniculate body of the thalamus, and from the thalamus onto the cortex. If we look at a full specimen of the brain, we can see here the fibers coming up through the eighth nerve, up through the brain stem, coming up to the midbrain, to the inferior colliculus, onto the medial geniculate, and then onto the primary radiations up to the auditory cortex. And we see here the transverse temporal gyra, area 41. These pathways are laid out from the hair cells all the way up through the brainstem, crossing multiple locations in the brainstem to provide information both to the contralateral auditory cortex, but also fibers come ipsilateral to the auditory cortex. So there is bilateral projection to the cortices. If we look at a fresh brain and open up the lateral fissure, we can see the transverse temporal gyrus on the superior portion of the temporal lobe here. You can also appreciate that pathway schematically, coming from the hair cells into the cochlear nuclei at the pontomedullary junction, and gradually crossing to the from the superior olivary complex through the trapezoid body up to the lateral lemniscus and thalamus up onto the cortex. Of note here is that the dorsal and ventral cochlear nuclei pass immediately adjacent to the cerebellar peduncle, the inferior cerebellar peduncle, so that damage to the eighth nerve is also likely to influence functions of the cerebellum through this structure. There are two major types of hearing loss. One is conductive hearing loss, and that's from the outer and middle portions of the auditory system, and most commonly either involves something like wax, cerumen in the external auditory canal, or otitis media, where there are infections that involve either the middle ear or possibly the external portion of the auditory path. Sensory neural hearing loss involves damage to hair cells themselves, that is the neural component of the auditory system, or to cranial nerve 8 or the cochlear nuclei. Middle ear disease commonly involve infections, otitis media or other infections, or otosclerosis, an aging effect on the bones associated with hearing. Produces a conductive loss because there's less amplification of sound provided by the bony structures within the middle ear. Damage to the facial nerve in the brainstem or the temporal bone produces a Bell's palsy, which has an interesting effect on the auditory system because the facial nerve controls the excitability of the auditory pathway. And if there is damage to that facial nerve, there may be hyperacusis, an increased sensitivity to loud sounds. This facial nerve provides an inhibitory role on the auditory system for loud sounds, and is something like the effect of the gate control of theory in the somatosensory system, pain system, where large sensory fibers control conduction within the pain pathway. In this case, there may be hyperacusis seen with damage to the facial nerve. Presbyacusis is an effect of an age-related sensory loss, and this is an effect in which there are commonly hair cells lost at the base of the cochlea. And commonly there's a loss of high-frequency sounds in particular. Otosclerosis is due to remodeling of some of those ossicles within the middle ear, and there leaves those bones unable to convey sound from the outer ear to the inner ear effectively, and it produces decreased hearing. Sensorineural hearing loss can occur from a number of locations. Direct damage to hair cells, which is very common, particularly as a result of exposure to loud sounds. Occupational hazard is one of those, as well as wartime settings where people are shooting guns that are sitting over there on their shoulders. But also certain prescription drugs, some of the antibiotics that will produce, such as gentamicin, can kill off some of the hair cells. And high-frequency hearing loss tends to be affected primarily. Damage to the cochlear portion of the vestibular nerve or the central portions of the auditory pathway can also produce sensorineural hearing loss. Damage to the cochlear portion of the cranial nerve 8 or the cochlear nuclei in the brainstem at the pontomedullary junction can produce a very profound hearing loss. It's unilateral if the lesions are unilateral. Cerebellopontine angle tumors, among them acoustic neuromas, also known as vestibular schwannomas, are common causes of this kind of loss, but also meningiomas and astrocytomas or metastases can cause this effect. In addition to causing the hearing loss, one of the more disturbing features of sensorineural hearing disorders, tinnitus. There's a ringing in the ear that might be persistent and very intractable and difficult to control. Lesions to some of the more central auditory function structures in both the midbrain, thalamus, and cortex may also result in a decrease in ability to localize sound. And then a variable hearing loss, sometimes with little or no hearing loss, with damage to the cortex if it's ipsilateral. We can see here an example of an acoustic neuroma here in this horizontal section, T2 weighted MRI image. We can see a tumor that impinges on the 8th nerve, the pons, and cerebellum. We see the same, and you can see because it's a T2 weighted image, you can see the vitreous is also white. If you look at the T1 weighted image with an enhancement utilizing ProHance, we see that there's a cystic structure with a membrane around it. We see the same lesion represented here in a coronal section, and we can appreciate that it impinges both on the cerebellum and on the brainstem. And here at the midline, we see no abnormality, but if we look off to the side, that is off what appears on this side. This is the left side. As you can see, it appears right, but that's the left side. If we look at this for a parasagittal section, we see the same lesion right here, again impinging on the cerebellum, whereas on the opposite side we see no insult. As indicated, unilateral lesions on the hair cells or the cochlear division of 8 or the nuclei themselves often produce a profound hearing loss, that is in this region. Whereas Unilateral lesions at B or above, that is at the lateral lemniscus, inferior colliculus, medial geniculate, and superior colliculus. They may affect sound localization, sound in space, so that you know where the sound is coming from, but often have little or no effect on thresholds, hearing thresholds themselves. They may influence the clarity of certain sounds. Tests for conductive and sensory hearing loss include the Rene test, in which air conduction is compared to bone conduction. Now, normally, if you take a tuning fork and you listen to it in the air, you have better sensation of that sound than if you have the tuning fork attached to bone, because there's an effective amplification by the middle ear and the outer ear of sound. Whereas if you have sensory hearing loss, you tend to have the same effect where air is better than bone. But if there's a conductive hearing loss, that is, if there's plugging either of the external auditory canal or the middle ear, then air conduction is not very effective, so that bone conduction is better. And in this case, it helps you to identify that this person was a hearing loss. If they have bone conduction is better than their air conduction, it tells you that they've got a conductive hearing loss, and it's in those middle or outer ear portions. The Weber test, on the other hand, allows a different form of localization. And normally, if you listen to a sound by putting a tuning fork over the top of the head, you'll hear sounds as if they're coming equally from both sides or from the middle of the head. In a conductive hearing loss, if you present the tuning fork on the surface, then the tone will appear louder on the side that is damaged. And if it's a sensory neural hearing loss, then the sound will be better in the normal ear. Another way to examine the auditory pathway is using an electrical measure, the auditory brainstem response, or the brainstem auditory evoked potential. In this case, sounds are presented to one ear, and we record from electrodes sitting on the scalp and one over near the temporal bone, on the skin, both on the skin. And if you record over a period of 10 or 15 milliseconds, you can find a number of consistent waves that appear. You see wave 1, 2, 3, 4, and 5. It turns out that the very first wave is generated by the 8th nerve. The second wave, second bump, coming up here, is generated by the cochlear nuclei. The third by the superior olivary complex, the fourth by the lateral lemniscus, and the fifth by the inferior colliculus. Later waves are inconsistent and are not useful for localization. But this series of waves provide a non-invasive measure with no radiation and a very easy way to assess conduction within the pathway from each ear. And if there is damage at a particular location, for instance, if there is damage at the inferior colliculus, then waves 1, 2, 3 might be present, but the later waves, 4 and 5 or just 5, may be lost. Or if there's damage in the brainstem, but not in the 8th nerve, we may see the first wave come through, but if the damage is at the cochlear nucleus, these later waves may be diminished or obliterated. So it's a very convenient way to assess function within that auditory pathway. We see the vestibular system represented here, in which you have the vestibular nerves, and we also see the important vestibular apparatus. The semicircular canals represented here in yellow, these loops, when we have 3 of them, as well as the utricle and saccule at the base of those semicircular canals. What is the vestibular sense? It's very different from other senses. It's usually not prominent in consciousness. Although we can tilt our head and activate that system, move our head from one side to the other or rotate it, we're not actually aware of the vestibular apparatus. But it is very essential for motor responses and for eye movements and posture. And when the vestibular system doesn't work, it becomes very prominent in our consciousness. It causes nausea, vertigo, this sense of spinning. It literally can produce vomiting, and it produces inability to stand upright. What exactly is this sense? It's a series of receptors in the vestibular system that respond to two major kinds of movement, either spinning of the head, rotating of the head, or to changes acting on the overall position, such as tilting, just tilting the head slightly. We have steady measures of the level of tilt of the head, and we have other measures of spinning of the head. That information is transmitted to the brainstem through a variety of connections to the vestibular nuclei, and then from the vestibular nuclei to two major areas, to the motor nuclei that control the extraocular muscles and control where the eyes will move, and to the lower motor neurons in the spinal cord through the vestibular spinal pathway, and that'll control posture and position of head and neck. The end result is that this vestibular apparatus coordinates between the head movement and body movements, enabling the eyes to maintain their fixation even as you move your head and even as the head is tilted. And those are referred to as the vestibular ocular reflex, those adjustments of the eyes to move to activation of the vestibular system. The apparatus responsible for that is reflected over here as we see the three semicircular canals. They're at orthogonal orientations to one another, and the utricle and saccula. The utricle and saccula contain macula, the location of hair cells that are the sensory receptors for the vestibular apparatus, and the semicircular ducts, which have cristae at the end of each of them that are sensitive to movement of fluids within each of those semicircular ducts. The ampulla of the semicircular canal is shown here. It's a recessed area, and within that is the cristae, and the cristae is sensitive to movement of fluid and is able to detect orientation of the head associated with rapid rotation, whereas the macula is sensitive to static positions of the head and orientation of the head in space. The hair cells are shown here, and we can see that the hair cells within the otolithic membrane are in a gelatinous setting in which otoconia are represented up in this membrane, and it's the activation of these hair cells by their connections to these otoconia that determine the excitatory input to the supporting cells that eventually will send an excitatory input into the vestibular eighth nerve fibers. Linear acceleration produces activation of movement between the otolithic membrane, this membrane relative to the hair cells, that results in signal transduction. We see an electron microscope of some of those hair cells, and we can see the hair cells represented here in a gelatinous region in the semicircular canals, and it's when this gelatinous region moves relative to the hair cells that activates transduction that results in opening up of potassium channels that activates voltage-gated calcium channels, result in release of neurotransmitter onto the peripheral process of the vestibular fibers. We can see that otolithic membrane represented here, and some of the otoconia that help to influence the response to tilting of the head because they have a response to gravitational forces. We see here the large hair cells, stereocilia, and the receptor cells, supporting cells around them, and the input to peripheral fibers from the vestibular apparatus. In the semicircular canals, fluid is able to move rather freely, so that if this semicircular canal sitting in the head is rotated in this direction, then the fluid, which has inertia, will move relative to this canal in the opposite direction. When it moves relative to that bone, then it will deflect the cupula which sits within the ampulla. By deflecting the cupula, it will activate cranial nerve fibers, and that's the form of stimulation. And the same thing happens in each of the semicircular canals to activate hair cells. And we have those at orthogonal positions within the head on each side.
The semicircular canals on each side are influenced by rotation of the head, and we can see that if the head turns to the left, then the semicircular canal on the left is excited, while the semicircular canal on the right is inhibited. That input will travel down through the vestibular nerves on each side, and they will influence both the vestibular spinal tract, which influences the tone of muscles in the body to compensate for those movements, and will activate extraocular movements in order to complement that movement of the head. So that if the head is turning to the left, the eyes will turn to the right automatically through this system in order to sustain fixation.
The inputs of vestibular nuclei to the vestibular nuclei are shown here. The inputs come from the cerebellum to the vestibular nuclei in the rostral medulla caudal pons at the pontomedullary junction. And there's also input from the sensory neurons and from the contralateral vestibular system. These have a very important role, as we said, in influencing eye movements as well as motor activity throughout the body. The vestibular nuclei are seen here, and that is coming in. We have the cranial nerve dorsal and cranial nerve nuclei for sound, but we have the vestibular input coming into this region, immediately adjacent to the cerebral peduncle. And this is at the pontomedullary junction at the rostral medulla. We can see that it's also close to the spinal nucleus of cranial nerve 5. And we have both the inferior vestibular nuclei as well as the medial vestibular nuclei. And we will not differentiate between all of these, but just recognize that we have vestibular nuclei in the dorsal lateral portion of the medulla, of the rostral medulla. Outputs from the vestibular nuclei, as we indicated, will travel down to the vestibulospinal tract, and we will lump them together, both the lateral and medial vestibulospinal tract, to influence tone, particularly in extensor muscles, and then also sends inputs to the cranial nerves that are involved in moving the eyes. That is cranial nerve 6, and then through the medial longitudinal fasciculus to cranial nerves 4 and 3. 3, 4, and 6 are involved in eye movements, and the vestibular output has a very strong input on those eye movements. The vestibular ocular reflex is represented here, and what we can see is that when you activate by turning the head, and you might want to demonstrate this for yourself, if you look at this screen and you turn your head, your eyes tend to stay right where they are. And the ability of your eyes to stay where they are when you turn your head is because the vestibular apparatus activates the semicircular canals, which send input to the vestibular nuclei, from the vestibular nuclei into the abducens nucleus, that is the 6th cranial nerve nucleus, and they will activate those muscles appropriately to compensate for the movement of the head, so that the eyes will move in a direction to maintain gaze in the position that it originally was. That turns out to be a very useful measure. It happens naturally, but it's also a very useful measure to assess an individual's integrity of various portions of the brainstem. And you'll see that used in patients who are comatose, who are not otherwise responsive. You can passively move the head, and it should activate these pathways. And if they're intact, when you turn the head from side to side, you should see the eyes moving back and forth. There are also cerebellar areas involved with eye movements, and those are the floccular nodular lobe, as well as portions of the vermis, and they interact through these systems that we just discussed. Vertigo is a very strong sensation of spinning, even while you're stationary, and it often is associated with nausea, and it is one form of dizziness. Dizziness is a very common symptom, and not always can be so well localized, but vertigo is one that suggests very strongly that there's some portion of the vestibular system that is abnormal. And it could be peripheral or more central. In the periphery, it tends to be involved with the semicircular canals, or the vestibular nerve infections, or something called Meniere's disease, in which the endolymph has increased pressure. And bouts of vertigo can be very disturbing. And often it's associated with tinnitus as well, that sound of rushing or different, as well as a feeling in the ear. That tinnitus may be associated with a ringing, persistent, disturbing sounds. And it can be often treated with diuretics or salt restriction to change the endolymph pressure. More centrally, it can be involved by a variety of different problems in the brainstem or the cerebellum, producing, whether it's from a stroke affecting the vestibular nuclei. You'll see pica and iaca. Those are major vessels coming to the cerebellum, but involving the vestibular system within the brainstem. Posterior inferior cerebellar artery, or the anterior inferior cerebellar artery. They influence both cerebellum as well as vestibular nuclei. We can also see other cerebellar abnormalities of strokes, tumors, and posterior fossa abnormalities involving cranial nerves. Another problem that may be seen is benign paroxysmal positional vertigo. In this case, the otoconia, those rocky-like material that's in the vestibular apparatus, may become dislodged, and as a result, there is some sense of movement even when there is not movement, and it can result from aging or head trauma, and people complain of vertigo with changes in the position of the head. It tends to habituate over time, but can be rather disturbing in that vertigo. It may be able to be treated with physical therapy, with actually possibly moving some of those particles.